I mean, okay, I'll start with the good news, right? So the
All
good
right.
news is it's not as deadly as we might have thought. So if 50%, 50 people had it for every person that we've identified having it, well, previously we're counting the number of deaths. We divide by the number of people we think have it. And we say, okay, gosh, 1%, 2%, somewhere between 1 and 2% of people who have it die. But if there's 50 people who have had it and cleared it in the
and that your test now picks up,
yeah, then you get a much lower fraction death rate. Now there's some more nuance to that calculation that's not worth going too much into. The bottom line is that once you do that nuance, it's probably about as deadly as the flu or a little bit worse per case.
Okay.
So instead of having a death rate of, like the World Health Organization said, 3 in 100, so you get COVID and 3 out of 100 people die. Instead, where our estimates suggest about somewhere between 1 and 2 in 1,000 die from getting infected with COVID. So that's the good news.
And what about the bad news? That it fills me with a certain trepidation because it suggests we're just getting started. If you'd said 30% have been infected, I'd have felt more relieved. But am I understanding that in the wrong way?
No, I mean it is in some sense it's bad news, right? So this traditional strategy to control new epidemics involves a strategy called contact tracing, right? So they find that Peter has the virus. Sorry, Peter.
Volunteer.
They quarantine you. Then they interrogate you and ask, okay, who else have you been in touch with? Oh, you've been in touch with Jay. Well, that means Jay now needs to get tested and possibly quarantined also, or isolated. And then you keep tracking outside until you've characterized the full set of people that Peter has been in touch with, and the set of people he's been that his friends have been in touch with, and so on and so forth, until you've sort of collared everybody that potentially could have it and tested them and move outward. And every time you find a new case, you do the same thing over and over again until you've identified everyone who has it. So if this many people have it, as we found, it is almost impossible to do that kind of contact tracing.
Because you end up with the whole population.
Yeah. Well, I mean, that's hopefully not the whole population, but it's certainly a very, very difficult challenge, even in the best of cases. But if you have tens of thousands or hundreds of thousands of people that need to get contact traced, then you just can't. There's no way to do it. It's just not a feasible strategy.
So back, if I may, to what the new information contained in your results about the coronavirus, this new coronavirus. Again, I'm summarizing things as best this little layman's mind can grasp them. But basically, we've been told that there are 3 ways in which the coronavirus differs from the ordinary flu. And the first is the long latency period. You can go a long time without becoming aware that you have it. And the second, which is related to the first, is the high infection rate. What was it that I saw figures that each person who came down with COVID-19 infected 3 others? Well, of course, that's exponential. You'll end up in real trouble very quickly. Well, do your results affect either of those 2?
So that second number you said, the three people infected, has to do with the policies that you follow. So if you have a shelter-in-place order, you're not, each person won't be infecting 3. I mean, that's part of the reasoning behind the shelter-in-place orders. So
the latency period what you've discovered is that the latency period is often infinite. Lots of people get this thing and don't even know they've had it.
That latency period has to do with the biological properties of the thing, but it certainly has implications for what we found. A lot of the people that have it probably never knew that they had it, have it and cleared it, and they could have infected other people very easily. It is very infectious, as you say. Even when you're
totally asymptomatic.
Yeah, I mean, I think it's less likely that you'll spread it if you're asymptomatic, but it's possible. It just makes it very difficult. So, okay, one more corollary to that piece of bad news that I gave you earlier. I mean, economists like to deliver bad news, right? The disease eradication is probably not possible. Like making COVID go away altogether from the face of the earth is probably not possible.
All right. I can live with that because I think I've already adjusted my thinking to that. Here's the third way, the third fundamental way that COVID differs from the flu. And I'm just going to quote Dr. Fauci, Dr. Anthony Fauci, and he's speaking early last month, early in March. Quote, I'm quoting him, "The flu has a mortality rate of 0.1%, 0.1%. This," meaning COVID-19, "this has a mortality rate of 10 times that," close quote. And your results say?
It's about the same as the flu on that order. It could be a little less, it could be a little more. So I guess now the estimates, I guess there's some nuance to them, and that latency period actually matters. So, I mean, we're presenting a conservative estimate. I think roughly it's on line with the flu. Like I said, it could be a little bit more. 1 in 1,000, 2 in 1,000, not 1 in 100, 2 in 100.
All right. You're conducting another couple of tests very briefly. You've got one that is underway or soon to be started in LA County, and another with MLB, the Major League Baseball organization. Just briefly tell us about that.
Sure. Yeah. So actually, the LA County study is in some ways similar to the Santa Clara study. But it's in a bigger metropolitan area. It represents about 10 million people. That data collection happened last week.
Oh, so okay.
That's all done. We're going to release the paper. Well, we sent it to a journal, and hopefully I can start talking about it very, very soon. And then the Major League Baseball study is with 27 different teams all around the country. Now it's the employees of Major League Baseball, not the athletes. In fact, it's mostly employees. So concessionaires, front office and back office staff.
But that gets you closer to a sample that's closer to the way ordinary, right?
Representative. I mean, they're unique individuals working for a unique organization, but they are a picture into 27 different community, places very, very quickly with an organization that has fantastic medical personnel and fantastic people to help organize a study that normally to get into all those places all at once would have taken years. Because of its Major League Baseball, now we're going to have a picture in those communities within a few weeks. We organize the study. It's
spectacular. And when will those results begin to become available?
Well, we just finished the data collection, so just all those.
Oh, you've done that as well.
Yeah, so we're going to.
You've been busier than I thought, Jay.
I've been very busy this past month and some. I'm gonna try to write the paper this weekend. We'll see how far I get.
All right. We'll speed up this conversation so you can get back to work. So, Jay, the implications of your study, I'll come in a moment to the implications for what we ought to do now. But of course, the first question is, what does the study say about what we have done? If I understand you correctly, and I hope I've misunderstood, but what's in my mind right now is that we have just shut down the economy and thrown, over the last month, it's in the Wall Street Journal this morning, 22 million people in the last month have filed for unemployment insurance. And those numbers are bigger than the nation has ever seen before. You're telling me that we shut down the American economy for the flu?
No, because the flu we don't have a vaccine for this thing. Many more people have died total for it. So it's not for nothing. I mean, we also didn't know the number, like we talked about last time. And so people were reacting to a scenario where it just looked catastrophic. 2 million Americans dead. That would have been catastrophic. I mean, so I don't really want to spend time too much on recriminations, Peter.
No recriminations, because people were behaving they were within what has been done was within the realm of reasonable action.
Yeah, I think so. Okay. I mean, I think, we could go back and second guess, but it's not productive. I think what is productive is to think about what the right thing to do is now that we're starting to have a good picture,
Correct.
A better picture of how extensive the epidemic actually is and where we actually are. I think, so one of the major themes has been, and completely reasonably, like, when is this virus most deadly? Well, it's most deadly when you are living in a place with an overwhelmed hospital system or healthcare system or nursing home or whatever it is. You get a huge amount of viral load floating around. People the people who are taking care of the patients themselves are getting sick. Milan, Wuhan, New York. We've seen dramatic evidence that this virus can become incredibly deadly when it overwhelms healthcare system. So that's the basis for the famous "let's flatten the curve" kind of idea.
Right.
I think that's completely reasonable. We basically should work very hard to avoid that, right? Because that's when the virus kills people at higher rates. So how can we do that now? Well, now that we have an idea of how extensive the virus is and how deadly it is, let's rework those models with this improved understanding, and then see where in the country we're anywhere near. Are we, if we lift up the cap, would we get near the capacity of the healthcare system, if you will? And in places where that it's safe, it seems safe, then let's start to lift the caps. In places where it's not safe, with the new data, we're going to be able to make those much more accurate projections about what would happen if we lift the cap. In places where it's not safe, well, then we keep the cap on. The other thing is going to be very, very important is to protect the vulnerable. Right? If you're older or you have some other health conditions, we know this virus is deadly for you. So working very hard to isolate those folks. And you've seen it actually in that 3-phase plan. I think
that the president announced yesterday, right?
Have
you had a chance to look at that?
Briefly, there's not a lot of. I haven't had a ton of time to look at that. I have to confess.
All right, but it looks reasonable.
It needs to get fleshed out. I think the main thing I would add to it is let's do these kinds of studies that I'm doing. Let's do them everywhere.
Right.
And we actually get a picture in every community in the country, and actually, frankly, the world of where we are in the epidemic. And then we can start to make reasoned decisions about where it's safe to lift the cap.
And Jay, so you've already conducted 3 tests. The results of one of those tests are up today. The results of the other 2 will be up in another. Well, if I can let you get off the computer and get back to work, you'll get that done sometime next week, perhaps 10 days. You'll have 2 more results. What other kinds of tests are taking place in the country? Yeah, is the country engaged in the kind of testing regime that you believe ought to be taking place right now?
Yeah, I think people all over the country, actually all over the world, are starting to do these kinds of studies. And I saw someone in Germany. There was one in Denmark. There's one in Finland, I think. They're coming out all around the world because this is exactly the kind of information you need to make the right kind of decisions. And in the U.S., I know there are groups all over the country that are gearing up to do these studies everywhere. I'm going to try my hardest to get to start to help to make those, but it won't be me. It'll be lots and lots of people doing these kind of studies.
Okay, so if I may ask, roughly what does a study like your Santa Clara County study cost?
Well, we did that kind of on a shoestring. If we had a professional organization do it, maybe $200,000.
$200,000. So the Federal Reserve has made $2.3 trillion in emergency lending available. Congress and the president, Congress passed and the president signed a $2.2 trillion stimulus package. We've shut the economy down for 6 weeks. That's got to be at least 2 or 3 trillion off the GDP. Should it be little groups running around scrapping to get their hands on $200,000 at a time be doing this testing? What? 6 weeks ago, why didn't Fauci say, Mr. President, I need $100 million to the CDC to start serological testing the moment it becomes available across the country? It just feels to me as though the feds, you're serious. The feds are serious about the wrong things.
Well, I think part of the issue is that, as we talked about last month, the tests themselves are relatively new. And I've learned a lot about the characteristics of these tests and the errors they have in the course of doing this research. It's stuff that people didn't know. I didn't know a month ago. So I think the worry about the error rates of these tests have slowed down some of the spread of these kinds of studies. Obviously, it hasn't slowed everybody down, but maybe I'm foolish to have gone ahead. But I think it was the right thing to do because I believe this is critically important information, even though I know the tests are going to get better as better research gets done on them by immunologists all over the country. In a sense, like I'm rushed ahead because I think this number will help make policy an early version of this number, even if it's a little more error prone than a late version of this number with better tests, is incredibly important. Is my view. And I mean, I think we'll see. I mean, I hope that people take this number and start to, put into their models, sort of a better and more accurate picture of how extensive this disease, this epidemic actually is. And I think they will.
So testing, you're rolling out more tests. That's weeks. More tests are springing up here, there, and everywhere. That's weeks and months. A year from now, 2 years from now, as we adjust to some sort of regime of permanent vigilance, you and I discussed this last time, and you said between SARS, there have just been too many outbreaks over the last decade or decade and a half. This is a new normal. You recall saying that. So is it too much to ask, to imagine at least, that CDC or somebody becomes charged with a regime of regular testing? What's in my mind, correct the image I have in my mind, is something like polling during a political campaign, where we understand the statistical analysis involved. You can use small samples to represent big samples. You know how people are infected in a certain city. You have a snapshot of the entire nation, state by state, county by county. We get very good at the testing. Is that what we need?
Yeah, I think so. I mean, I think that would be a really, really a big step forward, so that when something like this happens again, and it will, we can much more rapidly deploy this kind of like testing apparatus across the country. I mean, it's polling is a good example, a good analogy with it. I mean, the other one is unemployment numbers, right? The unemployment numbers are based on a study of 100,000 people conducted every month by the Bureau of Labor Statistics. Every month, they just go and ask 100,000 people, did you work this month, or something close to that? And that's where the unemployment numbers come from. We could have a panel like that for this kind of like disease tracking. And then as soon as a new disease comes up and tests start to get developed for checking it, we just go to that same panel. And
we have the equipment already in place. What about the civil rights aspects of this? We're in a phase right now in which you and I are seated where we're seated because the governor of California has told us to go home and stay there. You're in the office because you're an essential worker.
I got a letter. Did I tell you my letter?
I haven't seen that letter, but if you're not essential, nobody is. But can you get a rigorous enough permanent regime of testing based on volunteers only?
Yeah, I think so. I mean,
you can? Okay, so there's no
the BLS, the Bureau of Labor Statistics. They're not forcing people to answer their questions about, are you working? They're people who, they reach out to them and say, would you be willing to answer these questions? Say yeah, and then they ask them. I mean, people will say no. That's fine. I mean, you can make statistical adjustments for that non-response or the refusal. That's fine. I mean, I think, but there's no reason. That's not a reason to not set up that kind of infrastructure.
Got it. All right. A few last questions, Jay. India. We mentioned last week, you still have cousins back in India.
Uncles.
I'm sorry?
Uncles, aunts, you name it.
All kinds of family. On April 14th, that's just a few days ago, Prime Minister Modi announced a strict 3-week national lockdown. And here we are only a couple of days later, and he's already made clear that he intends to extend that 3-week lockdown. As I understand it, he hasn't yet said how long the final date will be, but it's going to last longer than 3 weeks. What implications does your study have for India?
I mean, it seems very likely that the disease is more widespread than people believe everywhere. I think India is going to start to do these sorts of serologic studies as well. And that I think they'll find the same thing, because I know I'm obviously this is a guess because I don't know the numbers from there, but that's what's happened in Europe. That's what's happened here. I think it's likely to be true in India as well. And the number, and because there are many very densely packed cities in India, the spread of the disease is probably more faster there than here. Now, of course, there's a lot we don't know about the virus, so that guess could be wrong. But again, it's just like we talked about last month. We won't know until we run the numbers there.
So, Jay, a question that slipped my mind until this moment. What implications do your numbers have for a concept that I barely understand, which is the development of herd immunity? Might we be farther along in developing a kind of broad-based immunity than we supposed earlier, or no?
You have to be careful about that. So this study and the antibody tests provide evidence that you had the infection. There's an active debate among immunologists and scientists about the extent to which these antibodies confer immunity. Right? So we don't know how long they confer immunity. If they do, it may be partial immunity, right? It may protect you partly from the infection, but not completely. So it's a little hard to say anything about herd immunity until that debate starts to get settled.
And that's not just a conceptual debate. Presumably there's going to be testing on that question as well. Is that so?
Absolutely. In fact, the vaccine development efforts that I'm sure you've heard about have to do with that debate, right? What antibodies actually confer immunity the best? And how do you induce those antibodies to form without actually infecting somebody, right? That's what the vaccine is about. So that's not anywhere near resolved yet. I mean, people are still studying that particular question. I mean, it's a new virus. We've only known about it basically the U.S. for 3 months.
Right.
So I'm not comfortable talking about herd immunity just because we don't know the extent to which
nobody knows what immunity looks like.
Yeah. So, but I think if we were to talk about herd immunity, 3-4% of the population is nowhere near that.
Okay. All right. Your advice for a few officials. If we could sit each of these down in your office and you could give them a sentence or two of advice, what would you have to say to the governor of California? You've just 2 million of people in Santa Clara County. You've just discovered what you've discovered. What would you say to the governor? What does that imply?
One, run these studies everywhere and keep running them until the epidemic's done. Right? That seems obvious to me, but and I'm sure that
and these studies only cost $200,000 a pop.
I mean, maybe I don't know how to do budgets, but I think so.
But the point is, if we're talking about Governor Newsom, we're talking about a man who has oversees an annual budget of well over $100 billion a year. There's room in there somewhere to run these studies.
I think these are really high value studies because, as I said, they're going to provide information about policy in a way that we desperately need. I mean, otherwise we're making policy on the basis of no real information. Or very little real information. The second thing is redo the models. Like you've seen these models about flattening curve, redo them once we have these studies. Take a very close look at the resources of the hospital resources available and ask, if I lift the caps, will I really stress the hospital systems or not? We could follow the same structure of the policy we've been following, except now with real numbers. It could be that many, many places around the country, including in California, it's safe to lift the caps. So the next step to me is run the studies everywhere, redo the models, and take a hard look and ask, is it really worth it to suppress the economy if I'm not going to stress the hospital systems and have COVID-19 patients die as a result of it?
Jay, everybody's talking now about modeling. And modeling means doing the most rigorous analysis you can and making the most reasonable assumptions, most realistic assumptions you can and projecting into the future. And there's a lot of modeling being done about the coronavirus. I don't see anybody modeling the health effects of what we're doing to the economy. You cannot engage in cost-benefit analysis unless you know the costs. So we know as a general matter that unemployment is associated with depression, alcohol and drug abuse, domestic violence, suicide. We know for fact certain that all kinds of hospitals are under intense pressure now. I just read a statistic the other day. The Mayo Clinic, of all places, is expecting a $900 million shortfall. Why? Because the procedures that they ordinarily perform have been stopped in favor because nobody will show up. We also know for certain that some number of colon cancers are going to go undetected because people are not getting their colonoscopies, that the pap smears are not taking place, that the PSA tests are not taking place. Who's doing the rigorous weighing of the costs of what we're doing? It just seems to me as though we have this very vivid image of, to the nearest dozen, how many deaths might occur under this scenario or that scenario or the other scenario. We've just shut down the economy and thrown 22 million people out of work. Nobody really seems to be modeling the health effects of that. Am I wrong about that?
You're not wrong, Peter. And it's even broader than you say, right? Because it's not just the United States. Nearly every country on earth has implemented these kinds of economic caps. The macroeconomic numbers are the global ones, incredibly scary. It looks like a Great Depression. It looks like on that order. And the health effects of that in the United States are going to be bad, as you described correctly. But in poor countries and in poor people in poor countries, it's going to be absolutely catastrophic.